Karen, would you like to come here or go up to, okay, Karen is going to go up and present her slides and then she'll come meet me.
Good morning. Just wanted to make sure I can advance them from here. So I'm Karen Steinhauser, and I'm a medical sociologist at the VA Medical Center in Durham and at Duke University Medical Center. And I was asked to speak a little bit more about the work that I've done on psychosocial and more recently spiritual care. And so the first slide that I have up here is, of course, Cicely Saunders, the founder of the hospice movement. And we can read this quote from her and realize that she was one of the first people to speak about the concept of total pain. Not only physical pain, but what other kinds of suffering do people experience in the context of serious illness, emotional suffering, spiritual suffering. And she then, many of the lessons that were learned in hospice, of course, came upstream and are now a part of palliative care. Let me see if I can advance the slide here. There we go. And I put this in. Of course, and it's not to deny where things might be going for some, but I often think of a dear colleague that I had and mentor who used to say, who had pancreatic cancer and only lived about 8 months after the diagnosis, and she said, you know, I know that this is going to kill me, but I really want to live as long as possible and as fully as I can for the time that I have. And I think we all understand you know, this experience when the research that we've done, when we've asked patients to talk a little bit about, we thought it was really important for them to talk about what was the meaning of death, and we had surveys about that, and we did qualitative work, and of course what they wanted to talk about was the meaning of life, and what they wanted to do even beyond talk about it was just experience meaningful life, have meaningful moments. So next slide, please. So I also wanted to point out that in the WHO definition of palliative care, I wanted to point you to notice that in this definition is the command really to address not only physical suffering but also psychosocial and spiritual. And I put this up here because of its uniqueness. How many definitions from the World Health Organization explicitly call us to address psychosocial and spiritual aspects of care? So really a mandate as well as a definition. Next slide, please. And additionally, and if you would hit it just again, the National Quality Forum framework that came out of preferred practices in hospice of palliative care talks about 8 different domains, and this was in 2006, about 8 years ago, and again, these 3 in the middle that are central. And next slide, please. And what we notice in the research in this area, there's a lot of work in trying to understand how are each of these realms of social, psychological, and spiritual, and when we look at distress and suffering and quality of life related to each of these, what is unique about them, and then where is their overlap? So we know ways in which they're distinct. In the spiritual, religious practices per se might be very different from that which would be addressed by someone in the psychological realm, which a psychologist or psychiatrist might address really symptoms of anxiety and depression, for example. But we have this overlap, and I would argue that all of these fields deal with this area that wrestles with issues of meaning and purpose, connection, peace, hope. We hear that language in all of those realms. And in our clinical care and in our research even more specifically, we have to get a lot more refined about how we understand it and how we approach this. What is in each of these realms, and what are the best interventions that we can find to address them? Next slide, please. And again, if you look at a panel that was convened in 2009 to come up with a consensus definition of spirituality. Again, we see this language about seeking and expressing meaning and purpose. And another thing, which I think many of you heard in the conversations already, connectedness. That relationship was so key. And for many, that connectedness may be to the self, maybe to others, it may be to the sacred or the significant. Next slide, please. So again, if only it were this easy that we could just Google. But I would say if we Googled what were the meaning of life, maybe what would be real is that we would get millions of hits, right? Because there is no single answer to it. As a sociologist, I think we are constantly, as humans, in search of meaning. And in our field, we talk about the distinction between meaning making and meaning taking. And traditionally, in more religious contexts, meaning taking is that we absorb the belief systems of an institution, of a religious tradition or a faith tradition. Our culture has become more secular and the authority of religious institutions relaxed, we're more individual, it's much more also about meaning making. What's important to that individual? And so meaning really is on the one hand what enlivens us, what makes us feel most alive, but meaning systems really, what is the lens through which we interpret this experience? How do we respond to it? And so crucial as providers and in working with patients and families to understand a little bit about what enlivens us going through that experience, but also what is the lens, what are our belief systems that we bring to this experience, which we can talk about a little bit more. And last slide, please. And then finally, a few words about, related to meaning, the role of spirituality, and a little bit about what we know from the research so far. So we know that it's integral to people's lives. Of course, our national polls and research just says generally across the life course, it's a really important aspect of personhood. But then when we look at research that's occurred in acute health settings, we know that, for example, the coping with cancer studies show that almost 90% of people said that spirituality or religion was very important to them. We also know in other studies, one study I'm thinking of that was in the context of palliative radiation, about 85% of that people in that study said that they had at least one spiritual need. And interestingly, even among there were 2/3 of people who said that they were neither religious or spiritual still said that they had spiritual needs. So again, we have to open up our language. So if we're wrestling with issues of hope or meaning or shame or guilt or forgiveness, those are really considerations potentially within the spiritual realm. We know, of course, that beliefs and practices are central to how we cope with illness. The research is very strong that for people who have kind of what we call negative religious coping, so frameworks that maybe they've inherited that include shaming or concern about a sense of damnation, have particularly negative outcomes around quality of life and even depression and anxiety when living with illness. We also know, again, from some of the coping with cancer work, that satisfaction and quality of life in the setting of serious illness are significantly higher when spiritual care is attended to. We also know that when people have unmet spiritual needs, costs actually increase. And we know that in terms of satisfaction and quality of life, we know the high rates, the importance of that in the population in general. And then if we look at African Americans and Latino populations, for example, we see even higher rates than we might see among whites. And then finally, as we know all so well, these beliefs, this lens has a strong influence on decision-making and treatment choices. So just a few words for us to think about. Thank you.
Karen, thank you so much for addressing some of the non-clinical needs that are so important to good outcomes for people and families. This morning, we were privileged to have a glimpse into the lives of people who were either providing or receiving care through very difficult times. Um, I'm I'm thinking about Blythe and the mother of Cameron, and thinking about the most difficult time, which was the not knowing, the time between having tests done and news delivered. As a person who also lives with serious illness, I remember that time very well. I think it must be different as a mother to go through this, but as a human being, it's a terrible, terrible thing to go through. Um, Tell me about what you know to be around the spiritual needs of people before they even know what is going on with them.
Well, one of the things that I heard you talk about was uncertainty, of course, and I heard it in both of the conversations. I heard it with Susie as well in terms of Doug, and that the real challenge. And I think a couple things that I heard in that uncertainty. First of all, there's some great work that's being done also in terms of trying to help support people. Psychologically, it seems that that uncertainty is so difficult for us because we can fill that space with stories that are very difficult, right? And I would imagine that that's an enormously crucial time to understand what are the beliefs that someone brings to the situation. Sometimes we have to open up and understand um, sometimes people have spiritual beliefs about why this has happened. Um, and, and it goes beyond the intellectual. So we can be very rational about knowing that there's a genetic component here. And that doesn't mean that there isn't there can be a simultaneous underlying belief system that sometimes can have some self-blame to it, can have a variety of characteristics to it. And so I think that's hugely important to open up and to um, allow into the conversation because it's at work within that person.
We also talked a lot about the relationship between the clinician and the person's family. Tell me a little bit more about the research in this area, about that relationship and its role.
Mm-hmm. Well, I was really impressed by the relationship that I heard from both. I mean, one of the first things that I heard, and this is in all realms about really terrific care, is that sense of non-abandonment. So even when there's really terrible news, that there's someone with you throughout that process. And that's what I heard from both Blythe and from Susie. Both had that sense that they could contact. Susie even had a phone number and used it, right? But so that relationship was central. I think that they were meeting the person exactly where they were and then acknowledging that they were going to walk through that journey, walk through that uncertainty together. And so when we think about, even in the definition of the spiritual, sometimes it has to do with our sense of connectedness to one another and to our beliefs, to the transcendent potentially, but also in the most immediate sense to one another. So I think that got displayed. I also think in the relationship, I found myself wondering about the conversation that Diane was having with Doug. And of course, that's protected and that's really private. But my guess is that if I were to imagine, I'm guessing that she's had some conversations about what was really important to him, not just about what was happening with him physically, but about what was happening with him emotionally, what was important for him to take care of, what was some unfinished business, what were some conversations that he needed to have with his children or with Susie. And so we didn't open up those, but I'm guessing that in a primary palliative care way, each of those providers were bringing those elements of meaning into that conversation, would be my guess.
So, if you, as a sociologist, had to make recommendations to clinicians about what they should be incorporating into their care of the seriously ill, what would be your top recommendations for them to incorporate into practice?
Well, I think, first of all, some of that commitment to the relationship was very powerful, which is, it does also, I'm not a clinician, but I mean, you can see what a sense of vulnerability that takes also to be willing to step into that uncertainty together and step into that space of intimacy. And then I think that there are some very practical things that providers can ask. And Christina Bukowski talks about this in terms of spirituality, to simply ask what's important to you at this time. How can I support you? Are there, is there a faith or beliefs that we need to bring into the conversation and talk about? Are there important beliefs that inform the choices that you're going to make that I need to know about? Is there a community that is supportive to you that we should be including in this? And then years ago, James, my colleague, and I and some others at Duke did a study where we asked people a question about, to what extent are you at peace? And that was, it could be about the peace with the treatment choices they were making, but it might be, they might respond more generally, to what extent are you at peace? And asking that question, I think, is an entry point. And people have to do it in language that feels comfortable with them, but it's an entry point into opening up. Where are their concerns? Where's their unfinished business? Where's there a little bit of snag of something that is not just about the physical experience, but it's about your emotional self, your spiritual self, that we might need to attend to, that we might need to talk through. And then knowing that provider, that some will be primary, but they might want to make a specialist referral also to a supportive clergy person around, to a chaplain, to someone else who can help address those needs.
So one of the things that we heard both of our family members talk about was around what I would call anticipatory grieving, preparing for what is coming down the road, and the importance of having help through that. So what can you tell us about that area?
You know, I think that there are, what the research tells us is that there are some very practical things that people want to often address, to have their affairs in order. One of the enormous concerns that we hear is the person themselves who's living with the illness, of course, wants to prepare, but the sense of wanting to care for family and not to have family be burdened, I would say, is almost rises above at times that concern for oneself. So I think preparing their family, that their family will know what to expect about the course of illness. We heard that Diane talk about that's part of the uncertainty. So I think walking through with people about things they might expect, walking the family through some very practical things about what they might expect physically, but then I think giving that information about what a potential course might be allows the person living with the illness and their family to start to think about, what are the important conversations that I need to have if that's the case? What are some goals of what I want to accomplish? What are things that make me feel really alive?
You're reminding me that my adult daughter, I talk to her all the time about, what will happen, what will come. The family will be supportive, and, I try to tell her how I'm doing now and what to expect. But it is the things beyond the illness that are the things that are of greatest importance. So we are in the process of decorating to her taste. I want to leave her remembering that I helped her do the things that are important to her. That it is not just about the clinical, but it's all about life.
Right. And I will say thank you. I mean, it's a beautiful example, and we hear stories like that so frequently. And in some of the research, one of the things that we found that was really important for persons living with illness was the ability also to contribute to other people. So flipping the focus so that it's not only about what do we need to give this person who's living with illness, but how can they contribute to others? Because we do that. We have that sense of generativity throughout all of life. That's always important. And so how do we continue that as long as we're living?
So this has been enormously helpful. I would like to call all of the panelists back up and we will then open up for discussion with our illustrious group in the room.